all the hours that they put in to get a variety of hospitals trained in all kinds of different scenarios. They've put in a lot of miles and driving across the state to get hospitals from the mountains to the coast to implement this new model of care, and they're going to tell you about the program and a special aspect of it that relates to movement and physical activity. And please join me in welcoming Sylvia Coleman and Karen Taylor.
Thank you, Dr. Bushnell. I'm going to come up here because they told me I have to. I'd like to be down there with you because that's where I told someone, I spoke on Tuesday at the Eastern North Carolina Stroke Network Conference. Was anyone there? Was anyone there? I recognize a couple of you. So you're not going to hear the same thing today, so that's good. That's a good thing. But I said, you know, I really don't know all that much. I just have a lot of great relationships. And that comes from being down there with people like you and getting to know you, because we use the 3-foot rule in Compass all the time. And if you don't know what that is, it's someone who will know someone who will be able to help you. And that's what we do with our patients all of the time. So thank you so much for allowing Karen and me a little bit of time this afternoon to talk with you about the Compass model, and specifically about the Movement Matters activity program that's a big part of it. But before we get started, just so I can get to know you a little bit better, how many of you are in here are nurses? Wow, lots of nurses. I'm a nurse too. Lots of nurses, so I'm in good company. How many of you are therapists, PT, OT, or speech? Awesome, because you're going to be really interested to hear about the Movement Matters activity program. And do we have any pharmacists in here? A couple of pharmacists in the back, yay, yay. And EMS, I know we have at least one, oh, 3, good. EMS professionals, so that's great. Physicians? You can raise your hand high back there. You can raise your hand high. And community resource folks, do community-based resources. Anyone from like a community agency? No. So are most of you from acute care? Most of you are from acute care, I see. Okay. Well, I'm going to ask Bill Jarrett, who is one of our awesome Compass providers. I'm going to ask Bill to tell you all very loudly, Bill, what you told me at the first break to get us started.
Okay. First of all, I'm Bill Jarrett. I work in neurology in Elkin, North Carolina. Such a rural, stand up, please. It's a rural community, small hospital system, and we've been involved with Compass for roughly 2 years now. And I think we're a testament to the importance of post-acute care. Acute care is always tends to be a focus with most stroke conferences. But post-acute care in our hospital, since we implemented Compass, our readmission rates have gone from 13% to 2 or 3. And it's held steady for 2 years. And so I think our hospital is a testament to the importance of what you guys are doing.
Thank you, Bill. And I promise I did not pay Bill to say that, did I? Did not get any royalties off of that. But the post-acute coordinator that worked closely with Bill told us that they didn't do anything else differently. And so it really is important that we get patients like Kelly. Kelly's going to talk a little bit about her post-acute experience in just a few minutes, but we get them emergently to the hospital just like she got there, and we do all of these great interventions, but we have to make sure that we don't just send them out and not know what's going to happen with them. We don't want them to come back to the ED. We don't want them to come back and be readmitted, and so it's really important that we have a good transitional care in place for them. So we won't take the time to go through these learning objectives in specific, but you can learn and you can look and see what they are. I think everyone in here knows that if you've had a stroke, you can be at increased risk for mobility problems, and if you are good chances you could fall, and if you fall, you could have a fracture, or you could hit your head or have a lot of other bad things happen. And so what we're going to talk with you about today is how we collaborate on behalf of these patients. Nursing, therapy services, primary care, community-based services, all to make sure that we're surrounding these patients and giving them all of the tools and resources they need to find themselves going successfully into the future. And I think just quickly, I know some of you were at the Telestroke Forum yesterday and you heard Dr. Bushnell speak about COMPASS, and I promise it's not going to be a repeat of yesterday, but we will have a couple of slides in here that may be the same, because it's important, if you weren't there and you don't know much about COMPASS, to know why we would embark upon doing this study. It is a 5-year study. It is a large pragmatic study. We got $14 million from the Patient-Centered Outcomes Research Institute to do this study, and we are working with 42 hospitals across the state. And why would we want to do that? Why would we be working so hard? We're in the beginnings of year 4. Well, if you look at these statistics here, you can see that a lot of people in the past have not gotten post-acute care. And when we talk with our post-acute coordinators, and those are the nurses, we'll tell you about the model here in just a moment, but when we talk with the nurses, a lot of them say, you know, before COMPASS, we really didn't know what happened to our patients. We hoped we didn't see them back. We liked them a lot, but we hoped we didn't see them back, but we really weren't sure what happened to them. And if they're younger patients, that was even more the case. And I'm from the South, as many of you are, and you know, what we call that here in the South is that's just a crying shame. You know, we can do better than this. You know what I'm talking about when I say that's really a crying shame. We can do better than this, and we should and we must. The other thing is we have really good performance measures for hyperacute and acute care, but we don't have performance indicators for post-acute care, so we don't really know whether we're doing a good job or not because we're not sure what to measure. So we're collaborating with our partners, including the Joint Commission, to develop some performance indicators for post-acute care. And if I could only have a minute or two with you guys on the elevator, and I could only show you one picture, this is probably the one that I would show you, because if you look, the patient and the caregiver is at the center of the wheel. They're right there in the hub, as they should be. And we're all surrounding them, doing all of the different pieces of our roles to surround them and help them find their way forward. And you can look on the wheel here in the circles around it, and you can see, you can find yourself. And that's really what we're all supposed to be doing. We're supposed to be communicating and collaborating on behalf of these patients. And so I pretty much have already spilled the beans as to what these services are. But they are, you know, critical services, of course, in the hospital, but when we transition the patient out, we want to start before they ever leave. And we want to make sure that we have nursing involved, we have therapy, we have social workers, we have discharge planners, we have hospitalists and all of that. But when they get out into the community, we want to make sure that we have home health involved, we want to have outpatient rehab, and when they get finished with all of that, we want to make sure that we transition them to community-based exercise programs. And they might need a lot of other things as well. You know, they might need help with their nutrition. They might need help with transportation. They might need a support group. Or the caregivers, we want to take care of them too, because the other part of this study, a secondary aim, is to make sure that we're decreasing stress and strain on caregivers. So they might need a support group too, or they might need respite care. So it's all of those services, including community-based services. That's what makes up the post-acute care services. And when we go into these 42 communities, we work with them to develop what's called a community resource network for their community. And that is not only the hospital folks and the key people in the community, but it's representation, like who makes things happen for stroke patients and their caregivers in your community. And they develop a core network, usually 10 to 15, sometimes 20 people, and then they develop what's called a community resource directory. So it's county specific and it's public facing on our website, and I'll show you how to get to it at the end. But we load all of these services in there so that it makes it really easy for the nurse and the provider to go in and figure out, once they know what the patients need, where to refer them. And I just want to show you this quickly to show you where we are in the life of the study. If you look at the yellow or gold star there, we'll show you that we are in phase 2 of the study, whereby all of these 42 hospitals now, some of them were early intervention, and they're in what we call the sustainability phase, and we're asking them and we're following them and studying how they're able to sustain the model. Remember what Dr. Bishop said earlier, it's important to be able, any good intervention, to be able to sustain it, and then the next thing we'll be doing is scaling it and showing that, that other sites outside of the study can do this. So that's where we are, and all of the rest of the hospitals as of April are in the intervention phase. And our goal is pretty simple, yet pretty mammoth. What we want to do is what any of us would want to have happen if we had a stroke or a TIA. We would want to make sure that we were moving along the lines of recovery and back to independence and to the best health we could. Right, Kelly? That's exactly what we would all want. That's what we would want. So that's our goal. I want to tell you, make sure that everyone understands who's eligible for COMPASS, although we're looking to expand this in the future. But for right now, it's all stroke and TIA patients who are at least 18 years of age and older who are going directly home. I will tell you 2 of our sites are piloting using this model in their inpatient rehab patients that are going home, and 1 site is already piloting using this for another chronic care management disease process, and that's congestive heart failure. And they must be able to speak either English or Spanish, and that's because, they have to be able to read the materials and the brochure on the model and that kind of thing, and everything is translated into Spanish. And I want to just kind of walk you through quickly before I turn over to Karen and talk specifically about how we've integrated the Movement Matters program into the model. But this will just show you here that the first step is to figure out who these patients are to begin with. So the nurse, typically the nurse, the post-acute coordinator, we ask that in any case possible, the nurse go through the whole 60-day period with the patient. So the first thing is to work with the team at the hospital and figure out who the patients are, and that's by running reports in whatever your electronic health record system is, and then going to like morning rounds, and talking with discharge planners and hospitalist teams and that kind of thing to figure out who these patients are, to begin the enrollment process, ideally before the patient ever leaves. Now, sometimes these TIA patients are in and out so quickly, and even our stroke patients are in and out sometimes within 2 and 3 days. So it's imperative that we identify them quickly and go ahead and get by and see them, the nurse get by and see them before they ever leave the hospital, and give them the COMPASS folder. And it's really, really important because that's the initial rapport. That is that relationship, because the patient is going to be a lot more likely to be successful moving through the rest of the model if they have gotten this initial visit in the hospital and gotten the folder. And you can see there, it looks like a yellow card. It's actually a magnet, and it goes on the refrigerator to remind the patient of the different touch points of the model in case they forget. They get a business card, the nurse's business card, so they know how to contact her or him. They get a brochure that's branded by the hospital's name and logo that says this is our model of care for patients like you going home, and they get messaging on blood pressure. All patients get messaged on blood pressure and get a blood pressure log. We encourage them to keep their blood pressure and bring it back to all of their providers. And then what happens next is they get a 2-day call, and there's an assessment done during that call. A lot of things can be picked up then. You know, we think the patient's doing just great when they leave the hospital and they get home and they don't have as much help and support, or maybe the caregiver doesn't show up. So it's really important to make a call within 2 business days. And we want to make sure that the patient understands their discharge orders, that they're following them, they have their medications, that they're taking their medicines, that if home health or outpatient rehab has been ordered, that at least a phone call has been made to initiate services, and that they remember what all of their follow-up appointments are, including their Compass follow-up visit in 7 to 14 days, and that they have transportation to get there. They come back to the visit, and hopefully that same nurse is there with the provider. It could be a nurse practitioner, a PA, or an actual physician. We have some neurology offices where the patients come back to, cardiology offices, hospitalists and transitional care clinics at hospitals, and even primary care. So a wide variety depending on what the community has available. And so the patient comes back, and their first 10 or 15 minutes is a very quick an assessment on the iPad. We provide the hospital an iPad, very quick to get at the primary problems, deficits, and needs of that patient. And that creates what's called a Handoff Report. Can be given on the iPad, or it can be printed off and given to the provider, so that when the provider comes in, they know what they're walking into, because this visit is to be about an hour. The provider might spend the next 20 or 30 minutes going over whatever assessments, medical and neurological, are appropriate for that particular patient. Now, if you're a provider, don't let this scare you. Not all patients get this, and Bill's smiling at me. Not all patients get this, but this patient here, we took a picture of him because he was a high-need patient. He got home, his caregiver didn't show up. He fell on his front porch. He was more cognitively impaired than we had thought. He didn't have his medicines, and he had several other issues. You can see he was a fall risk. He's got his little bracelet on there. So we needed to get him into a falls prevention program. We needed to get him into some rehab services, get him help with his medicines, and identify another caregiver. So it really is very specific. Dr. Bushnell has told us that sometimes she spends more time with TIA patients doing education than some of her stroke patients, and she's nodding her head. So if it's a TIA patient, when we get them back, we want to make sure that we're doing proper education with them. And all of this information goes into a data app, and it creates what is called an e-care plan or an electronic care plan. And that's what we have, all of those high priorities, problems and needs listed in language that the patient can understand, and we have their goal at the top. Their goal or goals, because we use a lot of motivational interviewing. If we want patients to take a lot of medicines that are expensive and have side effects, and we want them to eat a better diet than the barbecue or the high fat that we talked about earlier, we want them to exercise, and they say they haven't walked around the block in probably 6 or 7 years. And guess what? Here we are in North Carolina, where a lot of people still smoke and vape, and we want them to quit smoking too. So what's going to motivate them to do that? That's what we have to figure out and put on their care plan. So we share that with the patient. They get a copy, the caregiver gets a copy, and anyone else medically taking care of the patient, whether it's extended pharmacy services, primary care, all the primary care, home health, outpatient. And we do that by giving a code in a cover letter with a short note, so that they can go on the website and pull that care plan down. Because what patients and caregivers tell us is it's so confusing if you're not messaging all about the same high priorities. And that's what we want to make sure that we're doing. And we don't leave off there. We call them in 30 days and then in 60 days to make sure they haven't fallen off of the wagon with their care plan, or to see if they need some additional referrals. And I'm going to summarize here and turn over to Karen, but there are a lot of benefits of this care plan that patients, caregivers, providers, community resource folks have told us about But I think at the top, it really is patient-specific. It's very individualized. And so, you know, we just feel like this is the best way for us all to be communicating, collaborating, using that sort of as our individual patient Bible to help us get that patient moving forward. And we do hope to be able to, we're already studying how to use this if we tweak it with other disease processes. So I'll turn over to Karen there.
Thank you. So I'm going to talk a little more specifically about how our home health and outpatient teams would utilize these things and how we've developed some materials for them. So as specifically like home health nurses and home health and outpatient PT, OT, speech providers, you know, when you get this care plan for this patient, you're going to want to review that with your patient, go over all of their specific medical goals, and help them understand, can kind of base your education off of their specific vital sign goals and all of their, you know, all the issues we've identified as troublesome. Then you can use that to help them be better self-managers of their problems. So with our compass, instead of north, east, south, and west, we have numbers, engage, support, and willingness. And so when you are educating and working with that patient throughout your care time with them, we want everyone to be mindful about how their specific discipline would educate. So, you know, therapy, we don't historically talk to patients a ton about blood pressures, blood sugar levels, cholesterol numbers, but we want everybody to feel comfortable talking about all of these goals for them and how it relates to our discipline, so that that patient and that caregiver are getting the same message from everybody about what's important for them to help prevent having another stroke. So you can see, you know, each specific direction of the compass has specific things that we want to focus on with their education. So just a little background on why we're doing this. We know that therapy is very underutilized. So these numbers pertain to a Medicare population, people that have coverage. We know that still 59% of them did not receive any therapies, okay? Of the people that did, more of them received home health services than outpatient services. And this does not actually add up to 100%. Oh, it's 101%. A few of them receive home health and outpatient, just for those math geeks in the audience. But we specifically know that OT is very underutilized compared to PT. And so we also know that a higher intensity of services results in decreased risk of rehospitalization. So we want to be good at identifying during their acute stay the services they need, especially if they have funding for those. Let's get those in place so that you guys can follow up with them. A lot of times it's just not ordered. So for us, PT, OT, and speech are on the standard stroke order set, but that's not true at some other places. Also, often it's a very quick stay, especially if it's a TIA, and those services may just not get in. Sometimes they may see them and still miss something. So that's why that return, that 2-day phone call and that 7 to 14-day return visit, those are super important times to identify if a patient's had a fall, if a patient looks unstable, all of those things that even if we try to do a good job on the front end, we still may have missed something. And so we need to all be working together to make sure we're circling back and getting those services. Sometimes we ordered them, but the patient, home health showed up and the patient said, I don't think so. I don't think I want you to come in. So then that's another opportunity for Dr. Bushnell or Christina and Sarah, who are our APPs, to say, hey, we really think you need that, so let's go ahead and let them come. We're going to try again. So it just helps everybody manage better. So this is we've created a map to go with our compass because we're very catchy in the whole compass study. So our map is our Movement Matters activity program. It's how we kind of designed what we recommend for practitioners to, you know, how to implement everything. So we focused on overall fitness and health, upper extremity dexterity and function, and safe mobility and independence in the home and in the community. So when we created that, we didn't just create it out of thin air. We tried to be very evidence-based. So we used the American Heart Association and Stroke Association's guidelines for stroke survivors. We incorporated the CDC guidelines for all of their work on the STEADY toolkit. And we've put 3 evidence-based programs into our recommendations, which is the Otago exercise program for strength and balance, which I'm sure all our therapy folks in the audience are probably familiar with. GRASP is for upper extremity recovery, and that's something that's not hugely used in the United States, but pretty widely used in Canada and Europe. So those resources are on our Compass website. And then the LIFE program for balance and ADLs. And we really have 3 overall goals with our MAP. We want to help people, we want to prescribe a structured and progressive exercise and physical activity program, progressive being the optimal word. What somebody can do when they first come out of the hospital is not going to be the same thing that hopefully they can do 3, 4, 5 weeks later. So we want to be making sure when we intervene with folks that we are consistently being aggressive with them in pushing them to what they can safely do so that we're helping them maximize their recovery. We also want to match them with the appropriate health service setting. So is that home health for them? Is that outpatient? Are they safe to go ahead and just start directly into a community exercise program? So just being mindful at trying to figure out where they have benefits, what best aligns with their safety, and what they can personally do. And then we certainly want to align with healthcare quality reporting measures that are such big requirements, especially in the home health world. As Sylvia mentioned earlier, we also utilize this, our community resource directory, that when we go out and have done these site visits at every hospital, they have developed their own community-specific resource directory. So then that helps all the providers in that community know where to direct that patient and that caregiver so that they can really be well plugged into what they're going to need going forward. So the biggest focus for me for Compass, people always freak out when we're starting to train them, are like, what do you want me to do? What documentation do I have to do? Are you going to tell me exactly how to treat this patient? Because I am good at treating stroke patients. I know how to do this. Really, my big takeaways for Compass are communication and collaboration. Okay, so we want you to communicate with the advanced practice providers, the PCPs. If that person shows up to therapy or the home health nurse goes out and they just have this crazy high blood pressure, well, okay, what are we going to do to help them? Who are we going to communicate that back to? And how are we going to figure out, is that because they don't have their meds? Are they not taking their meds? Are they not on the right meds? All of that sort of stuff. So we want everybody to feel very empowered to communicate while you're caring for that person, to communicate with anybody you need to. And then as you finish your episode of care with them, it's not just, hey, thanks for playing. We're glad you got somewhat better. We're done. It's, this is this person's overall recovery going forward for the rest of their life. So what are we going to do to help them figure out what the next step is? Is that transitioning from home health to outpatient? Is that outpatient to community resources? What does that look like, and how are we helping that patient and that caregiver be better self-managers of their health so that they can continue to be healthy and prevent further strokes? So I'm going to talk a little bit just about how we've trained our teams. This is a huge effort. Like Sylvia said, this is 42 hospitals across the state. It is an enormous amount of people involved in this project, and that's hard. That really is hard to get all of those people trained. So our basic structure is that our PACs, which are the nurses involved in Compass, and our APPs, which are like Bill, all of our nurse practitioners, PAs, physicians that are involved with seeing them back in those 7 to 14-day visits. All of those folks come here for what we call Compass Boot Camp. So they get an intensive 2-day training on how the whole project works and what their requirements are. And then we as a team go out to each individual site, each individual hospital site that's going to be involved, and we bring all of kind of what we would call the major players to the table there: home health, outpatient, case managers, nursing administration, anybody, and then community leaders that are going to help with that community resource directory. Try to bring those all to the table and do a 1-day training with them there so that we get people up to speed. We identify Compass champions, which are therapy and nursing champions, to kind of be on ongoing calls with us on a biweekly basis initially, and then we transition to monthly. And then we also have another set of calls for APPs and PACs. So that's kind of how we continue to engage with them to see how they're doing, moving forward, training their own teams, because this is a train the trainer model. We're going to provide you the training, but then they are responsible for going out and training their site, their teams to be proficient with this model of care. So through that call structure, we provide ongoing troubleshooting. We, once we kind of have people up to speed and going in their individual sites, we kind of transition those to educational webinars that are just beneficial for ongoing stroke training and that sort of thing. And we do ask for them to each fill out surveys before each of those calls so that we know how things are going at their sites and where there might be problems. And we found that it works really well. We bring these sites on in phases, so we do a certain number of sites in each phase, and then we kind of move them forward. But we have definitely learned a lot of lessons from implementation with our HOP team, so I'm just going to kind of run through those real briefly. We know that change takes time. You know, asking people to use this optimized model of care takes a lot of effort. It's certainly not without a lot of intentional effort. So in sites that don't have great managerial support, upper level administrative support, it's a lot harder to implement that model. And it is hugely important to have good communication between administration and the frontline providers. Sometimes people will show up and be like, I don't know why I'm here. They just told me I had to come to this meeting. I'm like, well, that's not really setting you up for success. So, you know, communication is key. We have definitely learned that we need to start early and be consistent. Where we can identify our champions and get them to the table at that site visit, we've been much more successful than when we're trying to, you know, they send, maybe home health sends it in like a marketing person, and then we've got to go back and try to be like, well, we need a clinical person. So, you know, if we can get the right people at the table early on, it is very helpful. And we certainly find that if people are inconsistently represented on our HOP calls where we're trying to kind of move everybody forward with their training, it makes it much harder to implement well at that site. We just have to have organizational readiness. There has to be a willingness to approve time for people to get trained on the modules to help, you know, sort of know what's going on with our study. It definitely, timeliness in identifying the right people is certainly important. And we have definitely found that, like Bill said, where they've had good success, the most successful sites are places that were already very interested in kind of already doing the right thing, trying to go that extra mile for their stroke patients and trying to figure out new ways to do things. And we certainly see that in patient outcomes. I think we've already kind of touched on those. But we do know that sometimes the ask really is just bigger than what the champion is able to do. If we don't have administrative buy-in, then it's just really hard to do. And certainly, sometimes it's harder for frontline providers because we're all faced with productivity expectations and a very tight schedule, especially in the outpatient world where you're fully scheduled with patients all day and have very little control over that. We have often found that either trainers or clinical educators or kind of frontline management staff, but not super high up, have been the best people that have some flexibility to their schedule and can really engage in that training with us. So it just looks different every place depending on what their structure is and what their support level is. But again, this is a pragmatic trial, and so you just do the best you can with what you've got. We have definitely found that setting deadlines for tasks is important, and having a clear progression for how we're going to do our training is important. And like anything, making the materials you want people to access, making it easily accessible, and kind of just being right there with them along the way is very helpful. And it has been good for sites who have been able to share. You know, we do find that a lot of different sites have the same types of problems because they're all implementing the same basic program, that it's very helpful on those calls once somebody shares and it kind of gets a dialogue going, that we certainly have gotten some good shared experience out of that. So really, we have had a few circular problems. A lot of times sites will say, well, if we could see some more referrals, then we're willing to train our staff. But if you're not willing to train your staff, it's unlikely that your PAC may tend to send you more referrals. So we have had some issues with that. And we have certainly, as a team, had to be willing to try to re-engage sites that have been slow to come on, to do a lot of one-on-one training with them. If we've been able to bring them on later, then we need to kind of bring them back up to speed. And yet, we've had some good success stories with that when we've been able to do it. So Really, my biggest takeaway points would be that communication is hugely key to all of this, and that care transitions are very, very important. So being willing to communicate with your peers from home health to outpatient to figuring out what's available in your community, and then speaking, communication back to your PAC and APP who can help you with your care management of patients is really totally required to get optimal recovery for folks. So I'm going to transition back to Sylvia, who's going to share a few of our Compass success stories with you, and then I think Kelly's going to maybe come back and speak just a little bit more about her post-acute experience.
Thanks, Karen. This site here, UNC Lenoir, and I don't think anyone in here came to one of the last 2 boot camps. Did anyone come to Phase 2 boot camp? You may have heard Dawn Becker speak on our behalf. She's the post-acute coordinator for UNC Lenoir down in Kinston, North Carolina, and down east. And she has really embraced this model since their site visit, and really has used it to be their stroke program at UNC Lenoir. And Dawn is one of the people that she called me about 3 days after implementing the model, initially implementing the model. And she told me this story. I mean, this happened, this was like the first patient that they enrolled in Compass. And this patient went home on a Friday and had a caregiver lined up, supposedly, and she felt pretty good about him going home. And remember, supposed to call on 2 business days, but we always encourage our post-acute coordinators, if you can, call the next day, because if they're confused or they're having a problem, it's really good to go ahead and catch up with them. So she called on Monday morning, and this patient was an older gentleman. He was blind, legally blind. He was diabetic, and he got all of his care through the VA. And so when she called on Monday, things had not gone as he had planned. His caregiver didn't show up. He hadn't gotten his medicine. And so the fella on your right there, that's James Hood. He tag teams with Dawn. They have a paramedicine program in Lenoir County, and it's a great program. And the hospital cost shares, which I think is just fantastic. So the hospital pays for part of James's time. So Dawn called James and said, I need you to go out and see this patient. I'm not feeling good. The caregiver didn't show up. Anyway, long story short, the patient, it was actually worse than the patient was saying. He didn't have his medicine. He didn't have his insulin. His appointment with the VA was not for 2 weeks, so he was sitting there on 4 new prescriptions. And he didn't have food in the fridge, and a variety of other problems. So James relayed this back to Dawn, and Dawn was like, I'm glad we had that site-specific visit, because I met some people there I'm going to call. So she called the Community Care of North Carolina pharmacy director, who had been at the site visit, and explained the situation and said, can you help me figure out how to get this patient his medicines? And she said, I'll call you back in about 30 minutes. So she called the VA, the pharmacist, called the VA, and was able to get the patient, this was a Monday, was able to get the patient's appointment moved up to Wednesday. And she was able to work with pharmacy services in the community to get the patient's medicines enough to last him until he could get to the VA on Wednesday. And they worked with some other community-based resources to get him into some other services. And the patient, you're going to love this from a rehab standpoint, the patient said that, he did want to be able to walk up to the corner store. And you're going to remember this story from Eastern North Carolina. But he didn't really say why he wanted to walk up to the corner store, but we thought that, that's a great idea. Movement matters. We want him to be active. And so lo and behold, he was wanting to walk up to the corner store to get his beer and cigarettes. So In the interim, James went back and made 2 or 3 more visits to check on him. And on the next visit, a gentleman came by to see the patient while James was visiting and dropped off a bag. And James said, "What's in your bag?" And he said, "Well," and he opened it, and it was his beer. And he said, "Well, you said it wasn't safe for me to walk up to the store, but you didn't say I couldn't have somebody." So we have to be, James's point there was you have to be very literal with patients, okay? And then the next visit, another little bag dropped off. That was the cigarettes. He was like, "You didn't say." So anyway, that story turned out really, really well. And from there, Dawn said, you know, this is how we need to run our stroke program here. We need to not just take, she's a stroke coordinator there, and wears lots of hats because it's a small community hospital. But this has become their stroke program, and she works with them in the hospital and then to transition them out and then through that 60-day period. And I should have mentioned earlier, then we call patients at 90 days, and we survey them on their outcomes to see how they're doing. It's very functional status-based. It's the Stroke Impact Scale 16. So that's one story. Another rehab story, this is another highly successful site. This is Mission Hospital out in Asheville, and they have their own home health and outpatient, and it's called Care Partners. And the post-acute coordinator, Debbie, is standing in the middle. To her right is the backup post-acute coordinator, who is the post-acute coordinator now for the inpatient rehab patients that are being piloted to transition out when they're going directly home. And then the person on Debbie's left is their physical therapy champion. And she and a nurse champion really embraced this from the site visit going forward and worked very, very collaboratively with this team. They built a checklist so that everybody on the team knew what to do when, and they also started having weekly conferences. This is a large site on their campus patients to make sure that everyone was communicating and collaborating, and so they have done a fantastic job. And then I'd like to highlight a third hospital story, and I'd like to ask Emily Volk, our amazing post-acute coordinator from Northern Hospital of Surrey, in Surrey County, in the Mount Airy area. And you'll see Emily seated, second from your left, seated there. And then the initial provider was in the center. But this is an example of what a site-specific visit looks like. This is this hospital's community resource network, and we had everybody there from EMS. You were there, you're laughing, you were there. I recognized you when you walked in. There you are. And the gentleman on the right with the hat, he was from the faith community. We had pharmacy there, we had home health, we had outpatient. It was a fabulous day, wasn't it? And I want Emily to tell one of her good stories.
Thank you, Sylvia. So I've had several really great stories. The most recent one that I experienced, I had a late 60-year-old male who was seen in the hospital with a stroke. And when he went home, I did the 2-day call. He was doing fine, or reportedly was doing fine. And then he came in for his 7 to 14-day visit, and I try and do those very early, like maybe 5-6 days after hospitalization or discharge, so that we can really see what's going on early and intervene if we need to. So when he came in, he was walking very slowly and with a cane, and he had not received any therapy services, or nothing was in the pipeline. And I can't recall if that was ordered and just not scheduled or what the hang-up was. But so I had to really slow down, and I walk fast. Nurses walk fast anyway, and so I had to really slow down. And I was a little nervous about him only having a cane. I felt like he needed a walker. That's how bad it was. And so he came back. We did the visit, and we referred him for outpatient therapy. He was also uninsured. And so home health for him was cost prohibitive, and so he felt he could pay for outpatient services. So we finished our visit, and then I told him, give me a call if you need anything. I'll check back with you at the 30-day call. Well, a week and a half later, I was on our med-surg unit rounding on some patients, and out of the corner of my eye, I saw a man get off the elevator. And he walked, right into the corridor. He was coming to see another patient, and I looked at him, and I knew that I knew him, but I knew he could not have been the patient that I saw a week and a half earlier. But it was. And he was walking nearly at full speed. He did not have his cane. He just looked, so much better. And so I turned and I said, "Oh my word, I cannot believe how well you are doing." And he said, "I knew I recognized you. I thought maybe you were the nurse I saw last week." And I said, "Yes, you look fantastic." And so we just talked. He had been to outpatient therapy. He actually went the day after that we saw him in the office for his post-acute visit. And he was doing great. He felt much better. He had received really just the services that he needed with PT and OT. And incidentally, I did his 30-day call. So he's now a month out. I did his 30-day call this week, I think on Monday. And he's doing great. This was his last week of therapy, so they're releasing him, and he's really feels like he's back at his baseline, and just really pleased. So it was a testament to me of the effectiveness of this program, of us being able to just catch those seemingly really small and maybe things that we think are insignificant, but for this patient, it made all the difference and really shocked me, to be truthful. So it was a great experience.
Thank you,
Thank
Emily.
you.
Let's give Emily a hand. Thank you so much. That's a great example of how this model works. And last but certainly not least, I'd like to ask Kelly to come back up and join us for just a couple of moments. You heard from Kelly Tuttle this morning, our awesome patient stakeholder that agreed to be here with us today. And you heard Kelly talk about her front-end experience and the great outcomes that she's been having, but that didn't happen totally immediately. A lot of her deficits were gone by the time that she left the hospital. And she doesn't remember Gail calling her, but Gail, raise your hand, Gail. Gail did. Gail Wooten is our post-acute coordinator at Wake Forest Baptist Medical Center. And Gail did a 2-day call. And then from there, tell us what you do remember about coming back to see Christina at the visit.
I remember some of it. I remember bringing my mom with me because she would remember all the questions that I needed to ask. But, I met with Christina. I know that she did spend quite a bit of time with me. And I don't know. I mean, it was off and on for me. So
and Christina is one of our providers. She's a nurse practitioner in our clinic.
Yeah. And, so I remember that she went through all of my care that I needed. And she was a little bit upset with me because I wanted to go back to work, and she didn't want me to go back to work.
She felt like you weren't quite ready.
Right. So, yeah.
And what did she assess? She made a referral for you. Do you remember that?
The speech therapist. Yeah.
She referred you to speech therapy,
Mm-hmm.
and tell us about that.
That worked out really well for me. I think there was an appointment set up, but it was like a month out. So she was like, no, we're not waiting that long. So she did something that day that got me in with the speech therapist the next day.
See how we can pull strings, right? We have to be advocates for these patients. We can't expect to put them out after a major attack on the brain and just expect them to successfully be able, everything fall into place. when they're in the hospital, we can make it fall into place, right? We work fast, emergently, as Emily said, as nurses, we walk fast, everybody walks fast, we make it happen. But you put the patient out, and they don't know how to make these things happen. And even though her mother was trying to make it happen, her mother couldn't make that call and get her in the next day, but the provider could say, this is the situation, we need to get Kelly in, we can't wait a month. You know, we know that neuroplasticity is the earlier the better. You know, when the brain is retraining, we needed to get Kelly in quickly, and that's what Christina was her advocate to do that. Is there anything else you remember about your post-acute care? Any other services?
No, not really. I don't have a good basis of memory from the time that it happened until a couple weeks, maybe a month.
Okay. Well, thank you for, go ahead.
Tell us about your job.
My job. I finally went back to work 3 weeks after, and they let me go 3 days after. So I'm not working anymore. So if anybody has a job.
But she wants to work. And
Yes,
I understand that
I definitely
Rayetta is
want
on
to.
it, right, Rayetta? Rayetta, we're going to find her a job. So, so anyway, you know, it's that 3-foot rule that I mentioned up front. We meet people along the way. Someone will know someone who will be able to, and now there's 127 people in here that now all know Kelly, and we can, maybe we can even help find her a job.
I was doing purchasing. But I've got a pretty diverse background.
What company so we can boycott?
Don't put that on the
Might have, this is
It's
being
actually-
videotaped, so we might want to.
It's actually been bought out, so.
We're just going to find her a good new job, right?
Yes.
Good new
Yes.
job. Good new job. But we're so thankful that everything went as it did for Kelly in the acute, the hyperacute, the acute phase. That she was properly transitioned out. Her mother brought her back to the clinic so that she could get into speech therapy quickly, and she's doing very well today. And we're just so appreciative of you being here. So let's give Kelly.
Thank you.
Are there any